Hi there. This is Dr. Sujit Suchindran, an infectious disease physician and healthcare epidemiologist at Emory University School of Medicine. I work closely with the EASIL program. We work with medical directors from several nursing homes sharing patients with Emory Healthcare hospitals to improve the use of antibiotics to optimize patient care, protect patients from potential harms associated with antibiotic use, and reduce the threat of antibiotic resistance. The goals of nursing home stewardship programs, working as part of the EASIL collaborative, are to promote antibiotic use only when needed, minimize misdiagnosis, and ensure the right drug is used at the right dose and duration. This short video was created to deliver the key information on best prescribing for presumed bacterial pneumonia, what we will refer to as LRI for lower respiratory infection. At the end, you should know how to access and use the PDFs and pocket cards, what I refer to often as cheat sheets, to help you adhere to best prescribing practices for LRI for your nursing home residents. LRI treatment recommendations have changed. In 2019, the American Thoracic Society and Infectious Disease Society of America updated the guidelines for choosing the right drug and duration for LRI treatment. EASIL captured the key aspects of these national guidelines and applied them to the nursing home population. The take-home message of the new treatment guidance is 1. Avoid unnecessary antibiotic starts. 2. Shorter treatment duration is better. 3. Minimize fluoroquinolone use. Doing these 3 things should reduce unintentional harm among your residents. Okay, let's look at these recommendations in detail. First, use active monitoring when antibiotics are not indicated. Most of us are called about 2 types of residents with possible LRI: those without frank fever and those with a clear fever, temperature over 100 degrees Fahrenheit. In both groups, there is a role for a single day of active monitoring, without antibiotics, of patients that don't have sufficient respiratory symptoms, adding a laboratory test for RSV and influenza if in season, or COVID during the pandemic, or a blood count and chest x-ray if they have not improved the next day. If a resident doesn't have the required symptoms to justify antibiotics after 2 days of active monitoring, consider other infectious sources and non-infectious causes of pulmonary infiltrate, such as heart failure. We suggest approaching the decision of active monitoring versus empiric treatment in each of these 2 groups of residents. The afebrile group. Residents in the afebrile group need to have at least 2 respiratory symptoms to start antibiotics and have underlying comorbidities, specifically chronic heart, lung, liver, or renal disease, diabetes, alcoholism, malignancy, or asplenia. If it's a resident with COPD, they need increased sputum purulence and either dyspnea or increased sputum volume. For other residents with underlying illness, they need new productive cough and either tachypnea or delirium. Otherwise, without fever, the resident should be monitored actively with pulse oximetry, frequent vital checks, possibly a CBC, and reevaluated the next day. The febrile group. Use a standard definition of fever, such as the revised Loeb criteria, single temperature via any method greater than 100 degrees Fahrenheit, or 2 degrees above baseline, or 2 serial temperatures above 99 degrees Fahrenheit. If a resident is febrile and you suspect an LRI, to start antibiotics, the resident must have at least one of the LRI symptoms, which must include a respiratory symptom. The respiratory symptoms can be any of the following: new or increased cough, new or increased sputum production, pleuritic chest pain, respiratory rate over 25 per minute, or evidence of chest consolidation on exam, hypoxia, oxygen saturation less than 90%. Other non-respiratory symptoms can include delirium, acute functional decline, or elevated white blood cell count above 14,000. All of these symptoms will be listed on the cheat sheets and pocket cards. Note, if a resident has a high fever over 102 degrees Fahrenheit, LRI should be suspected and treated with new cough or rapid respiratory rate, but also likely transferred to an ED for evaluation. Second, after deciding to start antibiotics, choose the right drug. For most residents, this is monotherapy. This may be a big change for you. First-line antibiotics should be either amoxicillin clavulanate, i.e. Augmentin, or cefpodoxime or cefuroxime. This is monotherapy, just one drug. These are all equivalent, and the suggested dosage is in the cheat sheets. Only if the resident has a severe contraindication to the beta-lactams would levofloxacin be indicated for a mild to moderate LRI. Note that Z-Pax or any macrolide is not first-line therapy for mild to moderate LRI. There are several special circumstances that need to be highlighted. First, if a resident is deteriorating on oral agents or illness becomes severe, switch or start with ceftriaxone IM or IV and either doxycycline or azithromycin. This is to cover atypical pathogens in these deteriorating or severely ill residents. The next special circumstances are residents at risk for a specific type of pathogen. First, Pseudomonas. A resident should be treated with levofloxacin monotherapy if suspected to have LRI with Pseudomonas. These residents would be those with known history of Pseudomonas from a sputum sample in the last year or bronchiectasis. Second, MRSA. A resident should be treated with two agents, adding doxycycline to any of the first-line agents if suspected to have LRI with MRSA. These residents would be those with known history of MRSA from sputum, wound, or nasal test in the last year. The third special circumstance is residents suspected of aspiration pneumonia. In most instances, when aspiration is suspected, just use first-line agents and still only treat for 5 days. Here, Augmentin may be the best choice. Specific anaerobic coverage with metronidazole should be reserved only if abscess or empyema is suspected. Finally, after choosing the right drug, treat short, only 5 days in most circumstances. This is easy. The evidence has accumulated that treating for 7, 10, or 14 days for pneumonia has equal or worse outcomes than treating for 5 days. So, as a default, treat for 5 days. If on day 5 the resident is still febrile, using supplemental oxygen, or has unstable vital signs, then continue treatment to complete 7 days. Avoiding excess days will reduce C. difficile risk, re-hospitalizations, and deaths. The dosages and durations are listed in the cheat sheets, but as a default, think 5 days. This is the most consequential step of achieving a best practice for LRI in nursing home residents and really falls to you, the prescriber. At this time, let's quickly just point to where all of these details are located in the cheat sheets. First, the active monitoring versus starting antibiotics sheet. Use this to help you triage who should be monitored actively and who should start antibiotics. The dose duration sheet is the densest. On this, the first line and second line agents are listed, along with recommended doses and duration, and considerations about renal function. Note, mild to moderate illness are covered on the top, and special circumstances on the bottom. These cheat sheets can be printed out either as single page or as pocket card size for your use, or bookmark the link below. In summary, a take-home if you will, you now have access to some tools to help you practice best prescribing for LRI in nursing home residents. First, pursue active monitoring if antibiotics are not clinically indicated. Second, choose the right drug, almost always monotherapy. Third, treat for only 5 days. We have more information on our website, med.emory.edu/EASIL. Contact us if you have questions at EASIL at emory.edu.